So everyone can see my slide?
Yeah, no.
Yes, thank
Okay.
you.
So thank you guys for inviting me into today's event. So my name is Dr. Jeremy Go. I am an internal medicine resident in Capital Medical Center, Manila, Philippines, and would like to present our research, beta-3 adrenoreceptor, Boon or Bane in heart failure. So in today's speaking engagement, our objective is to study the role of beta-3 adrenergic receptor up and or down regulation in heart failure. We're also here to discuss the effect of beta-3 receptor agonism and antagonism and to review the effects of four selected beta blockers on beta-3 adrenoreceptors. So for our literature search, we've used PubMed, Medline, Crane, Herdin, and then for our study selection, we've keyed in the following words: beta-3 adrenoreceptors, beta blockers such as your metoprolol, selected beta blockers such as your metoprolol, bisoprolol, carvedilol, and nebivolol, and heart failure. So, for a briefer, the beta adrenergic receptors are divided into three main subtypes. Your beta 1, which increases your heart rate through the SA node. It increases your contractility and automaticity to the ventricular cardiac muscle and the AV node. Your beta 2, which is smooth which provides smooth muscle relaxation in your bronchi and increased perfusion and vasodilation of the blood vessels, and your beta 3. So your beta 1 and your beta 2 receptors are mainly found in the heart, but beta 1 more than beta 2 in the heart, causing positive inotropic and chronotropic effects on the myocardium induced by endogenous catecholamines. So for your beta 3 receptors, it rose into prominence starting from 1989, which showed that initially it has effects, pleiotropic effects on your brown fat thermogenesis, ileal relaxation, and your solus muscle glycogen synthesis. So here, this is a figure we've obtained, which shows figures on your beta 1 adrenoreceptors, beta 2, and your beta 3. And we're going to discuss them one by one. So let's focus on what is not found in your beta 3 adrenoreceptors. So I've encircled it here. So it lacks the particular amino acid sequences targeted by your protein kinase A or your PKA and your G protein coupled receptor kinase or your GRK2. So what happens because they lack the particular amino acid sequences, they make it resistant to catecholamine-induced downregulation, as we will discuss later on. So what happens in chronic heart failure, beta 1 adrenoreceptors and beta 2 receptors are desensitized and downregulated. We have loss of receptors due to chronic high plasma catecholamine levels. So in your beta 3 receptors, however, it's coupled to two different isoforms of G protein. So we can see in your beta 3, you have your G alpha stimulatory subunit, which is seen in your beta 1, and your G alpha inhibitory subunit, which is found in your beta 2 receptors. So what happens in brief is that when we stimulate your beta 3 adrenoreceptors, it activates the downstream pathways leading to the activation of the nitric oxide synthase or your NOS pathway. So this is a representation of the normal heart. So what we can see here earlier, we've said that in beta 1 is predominant in the heart, containing 80% of the receptors, where beta 2 has around 20%, while you have as insignificant levels of beta 3 in the normal heart. What happens in the beta receptors in heart failure is that beta 1, because more it's more predominant than your beta 2, more than beta 2 adrenergic receptors are downregulated. It's because of the phosphorylation by camp dependent protein kinase or beta adrenoreceptor kinase, which would lead to a decreased expression in your cardiac myocyte. So what happens, you have your decreased inotropic response to catecholamines, and the reason why we give beta blockers is that we want to upregulate the downregulated beta receptors. we can also see that what happens is that beta 3 adrenoreceptors are upregulated in heart failure because, as we've said earlier, they lack the phosphorylation sites for camp dependent protein kinase. So, there. So here, with the figure letter B here, what happens in your with your with your receptors in a diseased heart, the ratio becomes almost equal in a failing heart when your beta 1 receptors are downregulated, correlating with the severity of your disease. However, you can see here in the figure that myocardial beta 3 receptors, which are present both in the atria and the ventricles, are overexpressed in this type of disease, and it increases in quantity up to 2 to 3 times in heart failure. So what happens is that it counteracts downregulation with the signaling of your inhibitory adenyl cyclase or your G alpha inhibitory subunit. So what happens? It makes heart sensitive to catecholamine stimulation, and then the intended result is that it increases your inotropy. So, in briefer, which we will discuss in detail later on, what happens is that it activates the downstream pathways, leading to the activation of your nitric oxide synthase pathway, and that would lead to production of your nitric oxide, and that it suppresses your NADPH oxidase, bringing about its antioxidant effects. So here we've put a figure of the beta receptor, and its activation would lead to the following responses. So when we activate beta 1 and beta 2, it increases your camp levels. But the ironic thing here is that in beta 3, it actually decreases your camp levels. And when you decrease your camp levels, it decreases your cardiac contractility. But this effect is different when you have a normal heart, and this effect is also different when you have an ailing heart in patients with heart failure. What happens is that in beta 3 activation, you activate your nitric oxide, and it expresses its negative inotropic effect. So what happens in the normal heart, it inhibits cardiac contraction, excessive cardiac contraction and relaxation. But in the failing heart, it prevents pressure overload, and it acts as an endogenous beta 1 adrenoreceptor blocker. So it tries to not further downregulate the already downregulated beta 1 and beta 2 receptors. So it shares its negative inotropic effect in hearts through altered nitric oxide signaling. So here, this is a diagram that we've done. So what happens here is that when we try to stimulate the beta 3 receptor, we activate the NOS pathway, which increases your CGMP and your protein kinase G, and it would lead to these following effects. So for the vascular effect, what happens is that there is an increase in your nitric oxide production. So it would lead to an increase in your endothelial function and an increase in your coronary perfusion. It also contributes to myocardial function as well. So what happens is that your NOS pathway causes your myocyte relaxation that prevents excessive oxygen demand and ventricular remodeling. And the PKG activation reduces calcium oscillations that prevent your arrhythmia, hypercontracture, and sarcolemmal rupture, which unfortunately leads to cell death. Also, it decreases your NADPH oxidase or your nicotinamide adenine dinucleotide phosphate oxidase. So it brings its antioxidant effects. It downregulates your reactive oxygen species, and your ROS is said to deactivate the NAK ATPase pump. So it decreases your intracellular sodium, and then you have better inotropy because you prevent endothelial inflammation and myocardial fibrosis. So in summary, due to its vascular effects and myocardial effects, we have patients with with supposedly hemodynamic improvement in heart failure. So there are a lot of studies that prove the effect of your nitric oxide synthase in heart failure, such as in Carnicer or in Cotton, and in Manori, and then in Haywood. So the next segment of my discussion would be tackling about the specific heart beta blockers that are proven to be effective in managing patients with heart failure. So we're going to discuss first nebivolol, and it is shown here that it has greater selectivity of beta 1 adrenoreceptor blockages than any other beta blockers. In the graph here, it's shown to have a lot of selectivity compared to bisoprolol, metoprolol, and the like. They propose that that they also noted to have beta 3 adrenoreceptor agnostic function. So what happens? They exert its vasodilatory effect through the production of nitric oxide derived from the endothelium, such as in the image that you saw in your right. So there are some studies that shows beta 3 activity in nebivolol. So what they propose is that there is a synergistic action of nebivolol in the treatment of heart failure. So they divide it into two, the L type and then the D type of nebivolol when you ingest it in your system. So number one, what happens is that the highly selective beta 1 blockade reduces your heart rate at rest and on exertion and as well as your BP without causing adverse effect related to your beta 2 receptor blockade. So this is here. It maintains the balance with the alpha receptors as vascular level. But the other proposed mechanism is that there is vasodilation mediated by your nitric oxide release in your endothelium, which reduce your peripheral vascular resistance. So there's improvement of remodeling, you prevent arterial stiffness, you increase your systolic volume and ejection fraction, maintaining the minute volume. So the next top drug of choice that we're going to discuss is metoprolol. So metoprolol is a cardioselective inhibitor of your beta 1 adrenoreceptors, which also showed that there is minimal to no effects on your beta 2 adrenoreceptors. What we've seen is that it can also upregulate beta 3 adrenoreceptor expression. So there are some researches which shows a beta 3 adrenoreceptor upregulation as highlighted in the study below. And the conclusion is that your expression is increased in your failing ventricles. For your bisoprolol, it is also said that it is highly selective blocker of the beta 1 adrenoreceptor, but it has no effect on your nitric oxide generation. So what it does is that it promotes its vasodilation with its beta 1 adrenoreceptor effect compared to your nitric oxide, which you have with your nebivolol and your metoprolol. It is said here in the studies that we've seen is that they have a neutral effect to your beta 3 adrenoreceptor. So it's either upregulatory or downregulatory in mechanism. And the last drug of in study is carvedilol. So it is a non-selective adrenergic blocker plus an alpha 1 adrenergic receptor it also has alpha 1 receptor antagonist properties. So it has peripheral vasodilating effects which lead to a decreasing total peripheral resistance. It is also said that carvedilol has anti-proliferative effects on smooth muscle cells and that it inhibits oxygen-free radicals. But in comparison to the previous medications that we've discussed, it is known to downregulate beta 3 adrenoreceptors alongside your beta 1 and your beta 2. So what happens, they saw that the carvedilol binds to the beta 3 adrenoreceptors and it downregulates them. So in the medication review here in this slide, so what we've seen is that metoprolol and nebivolol has upregulation of your beta 3 adrenergic receptor action and they generate nitric oxide. Your bisoprolol and your carvedilol does not generate nitric oxide, with bisoprolol being neutral on its effect on beta 3 and carvedilol showing downregulation of the beta 3 adrenergic receptor. So what are the conclusions of this talk? So what we want to say is that the beta 3 receptor stimulation would lead to an activation of the NOS pathway and a suppression of your NADPH oxidase that causes vascular and myocardial benefits as we've shown in the diagram earlier, leading to hemodynamic improvements in patients with heart failure, and the use of beta blockers, regardless of mechanism and receptor activation or blockade, ameliorates your symptoms in a failing heart. What we've seen here is that the functions of the selected drugs in study, your metoprolol, nebivolol, bisoprolol, and carvedilol on beta-3 adrenoreceptors are valid. But however, their effects on on heart and patients with heart failure are well established. And studies on nebivolol and metoprolol suggest the upregulation of beta-3 adrenoreceptors that exert its nitric oxide production. So with that, I thank you guys for listening and have a nice day.
Sorry. It was a very great topic, and you never know that this one is doing that, this one is doing that. You just give. And it's very important, like if I'm also a wellness coach, so if I give education to my patients, I need to tell them certain things. Why did the doctor decide on this one and not on that one? It's very important. And I also see the change in pharmacists, that they actually start teaching the patients, because they don't understand. We say, when you talk to a patient, you will go to beta and alpha and delta and all those things. They don't understand it. But this was very good. Thanks a lot.
Thank you for your comments, ma'am. So I would just like to add something regarding to that topic. So we've all know that the beta blockers are already effective due to the studies that were done before the seniors trial, the CB's trial. We've known that it is effective in patients with reduced ejection fraction. But what's interesting in this topic is that even if we've been given these medications for a long time, we've been seeing newer mechanisms that would actually solidify our belief, the evidences that are shown that it is effective because of these mechanisms. And we'd like to explore that on a deeper level sometime if someone decides to expound further on the topic. So we will understand why these medications are being used aside from the known mechanisms that they are already known for.
I have a question. First, the lecture is beautiful. We know receptor 1, type 1 and the type 2. Type 3 is a new term, beta blocker type receptor type 3. Any drug of the known drugs or beta blockers can work on this receptor? Beta 3?
What I've seen so far is that the researchers focused on the well-known drugs because the medications I heard before that they formulated a drug specifically for the beta 3 receptor only, but it did not pan out or work out as much as they expected it to. So far as what I've read, it's great that it has an add-on effect or a beneficial effect in drugs that has a beta 1 and beta 2 activity. But in terms of the medications that were studied, these were the drugs that had the most mentions to in comparison to the other beta blockers that are not as used in patients with heart failure. So these are the ones that I presented.
Okay, thank you.
I must say, my name is Dr. Yochai Berenbaum. I must say that nebivolol was a promising drug that started, and they came with a new idea of very selective beta 1 antagonist and beta-3 activation. The only problem that first company that developed the drug lost the financial support because one of their bestseller antidepressant drug went generic and they lost income and they could not continue their research progress, especially in the clinical. They had one clinical trial that was neutral. And so by now, nebivolol is or about to become generic. Nobody will put any money on real good clinical outcome trial to show if it is better or the same as bisoprolol or carvedilol. And therefore, unfortunately, there is no real justification to use nebivolol, which is much more expensive than the other drug, unless you have specific indication and there is some work on erectile dysfunction because of the nitric oxide enhancing effect. Is it really important? Or those who complain of adverse effect and you think that there might be a placebo effect of expensive drug. So it's one of the many examples of missed opportunity. And it could have been that it would have been the best ever beta blocker for heart failure, but we don't know and we will not know.